Hello everyone and welcome back to Easy Ophthalmology. Today we are starting anatomy and it will be split into 4 different videos, starting off with the anatomy of the bony orbit. Then we'll discuss the contents of the bony orbit. Then we'll move on to the anatomy of the eyeball itself, and we'll finish off by some neurovasculature. So today we will be discussing the bony orbit, also known as the orbital cavity. And there are 5 main things that concern us within this topic. Starting off with the bones that make up the orbit, then we'll move on to the function of the bony orbit, and after that we will do a quick overview of the contents of the orbit. Although they have their own separate video, it wouldn't be fair not to mention them today. And after that, we'll dive deeper into some anatomic details of the bones that make up the orbit. And to conclude, we will finish up with some clinical relations of the orbit that you will run into during your clinical practice. I hope you will enjoy today's video, and let's get started. Alright, starting off with the composition. The bony orbit, or the orbital cavity, is basically comprised of 7 different bones. And the mnemonic I like to use to remember those bones is: many zombie eyes look pale from sleeplessness. So on the image on your left, you could see the zombie's pale eyes, and he's drinking coffee because he's sleepy. So if you remember this image, hopefully you remember this sentence. So how does this mnemonic help us? Well, let me show you. By the way, I suggest you guys familiarize yourselves with this illustration as it's very important. It shows all the bones, so if you know every bone's location, and hopefully you'll do by the end of the video, you could probably recall their names without the mnemonic. But anyways, many is for the maxilla, zombie is for the zygomatic bone, eyes is for the ethmoid bone, look is for the lacrimal bone, pale, palatine bone, from frontal bone, and finally sleeplessness is for the sphenoid bone. And these are pretty much the 7 bones that make up the bony orbit. Now we will talk about the function of the bony orbit. So as many of you can guess, its main function is to protect the eye and its surrounding soft tissues and structures. It also contains many fissures and foramina. Now, how do these help us? They basically allow for the passage of various neurovascular structures from the brain to the eye and also the face. As I said before, we will quickly go over the contents of the bony orbit, which you can see in this illustration. Now, obviously, the first thing you would notice is the eyeball itself. And as you can see, it occupies most of the space available. And I'd like to also point out that a majority of the space is also filled in by something called the orbital fascia. Now, what the heck is the orbital fascia? So the orbital fascia is a complex connective tissue membrane that's made up of 3 structures, one of them being the periorbita. So the periorbita is pretty much the periosteum of the orbital bones, but it's the periosteum of those bones from the orbital surface. Alright, that's pretty simple. Now the second structure that makes up the orbital fascia is the fascial sheath. So what's the fascial sheath? And you may notice there's 2 of them actually. So the reason is there's a fascial sheath that goes over the sclera of the eye, and there's a fascial sheath that goes over the extraocular muscles. Now the one that goes over the eye has 2 other names. It's called the bulbar fascia, which is pretty straightforward, and the other name is the more commonly used one. It's called Tenon's capsule. So this is the fascial sheath part that goes over the sclera of the eyeball. Now, as you go anteriorly, it kind of expands into the extraocular muscles, and it goes into all the extraocular muscles. And once it's there, it's referred to as the tubular sheath. All right. So I'll come back to the tubular sheath later in the next illustration, but now I'll move on to speak about the last part of the fascial of the orbital fascia, which is the orbital septum. So now we have the periorbita, the fascial sheath for both the muscle and the eye, and the third part is the orbital septum. Now the orbital septum, highlighted here, is a membranous structure that connects the palpebra or the eyelid, by the way, both superior and inferior, to the bones of the orbit. It also kind of connects or holds the fat with the orbit of with the bones of the orbit, so the fat doesn't herniate out of the orbit. And unfortunately, in many older individuals, the orbital septum weakens, so there could be a herniation, and if this happens, it needs surgical correction. So other structures within the orbit include the orbital fat, as I mentioned, the orbital fat, the extraocular muscles again, as I mentioned, and there's a couple structures you can't see within this illustration. I'll just mention them briefly and point them out in the next one. We have the lacrimal apparatus, we have the trochlea, and neurovascular structures, and the ciliary ganglion. Now in this illustration, you can see one of the lacrimal apparatus structures, the lacrimal sac. We'll cover the lacrimal apparatus in a different video. So going back to the tubular sheath, as I said, I'll speak more about it. So the tubular sheath is the part that goes around the muscles, the extraocular muscles, and there is a significant importance to the tubular sheath of two muscles, the medial rectus muscle and the lateral rectus muscle. This is because these muscles, their tubular sheath expands into the medial check ligament and the lateral check ligament respectively. So they kind of form them. And those ligaments are important because they help or aid in holding the eyeball in its place. And also one brief thing I'll mention before we move on is the suspensory ligament. Now, this is a bit tricky because the suspensory ligament, it's found in this area, but surprisingly, it's regarded as an expansion of the bulbar sheath or Tenon's capsule. So keep that in mind. It's a tricky info. So yeah, that kind of sets it up for the fascial sheath. It's quite long, but if you understand it, it's simple. And as I mentioned, there's some neurovascular structures, bunch of nerves, arteries, veins. There's the ciliary ganglion and the trochlea, which is a cartilage, by the way. The trochlea is the only cartilage within the orbit, and it's like a pulley that holds the superior oblique muscle in its strange conformation. And that's about it. So now we will dive deeper into the anatomic details of the orbit. You see, the orbit may be viewed as having a quadrangular shape. What I mean by this is that it would look something as such. Imagine this in 3D. So we have a point on top. This would be our apex, and this would be our base. However, it's flipped in the orbit. So over here we'll have the base, and down there we'll have the apex. You can see it clearer in this illustration. The apex is situated here. It's found posteromedially, and at the apex you can find the optic canal or optic foramen. This is where your optic nerve comes out, and the base opens anteriorly onto the face, and it's called the orbital margin or the orbital rim. It's basically a thickening of bone situated anteriorly, and in here in the illustration it's this thicker dark line. So it's basically just the thickening of bone. Why did the anatomists give it its own name as the orbital margin? So the reason is it has two functions, obviously protection being one of them. The second function is that it provides an attachment site for the orbital septum. Now I want to show you a quick video, and I want you to kind of observe the thickening of the orbital margin, and I want you to kind of observe the quadrangular shape I tried to explain earlier. So hopefully it makes it clearer. So yeah, I think the thickening is quite obvious. These thicker parts outside, those over here, this is our orbital margin, and it extends all the way around. And deeper, as you saw earlier, over here, it's not really visible anymore, but over here we had the optic canal. Now, I'd like to mention that the orbital margin actually has a bunch of borders. So we have a superior margin, lateral margin, medial and inferior margin. And I want to talk about the bones that contribute to them. So in orange, you can see that the frontal bone makes up or forms the superior margin. In pink, you can see the lateral margin, and it's formed by the zygomatic process of the frontal bone and the frontal process of the zygomatic bone. The inferior margin in black is formed by the zygomatic bone and the maxilla. But what part of the maxilla? The zygomatic process of the maxilla. So this is the zygomatic process of the maxilla, pardon me. Now the medial wall in blue is formed by the frontal process of the maxilla, but it's the frontal now, not the zygomatic. All right, now I will talk about the walls of the orbit. Now we spoke about the margin, the outer thicker part. Now we'll talk about the walls. We have a roof, we have a floor, we have a lateral wall and a medial wall. So the roof or the superior wall is formed by the orbital part of the frontal bone. So the frontal bone, it makes up the majority of it. And a small part is formed by the lesser wing of the sphenoid bone. I just want to point out that this is the lesser wing and this is the greater wing. Now there's one important landmark you should know in the roof, and this landmark is known as the lacrimal fossa. So it would be situated over here, and this lacrimal fossa hosts the orbital part of the lacrimal gland. So the lacrimal gland is split into two parts, the orbital part and over here our palpebral part. So the orbital part is inside the orbital fossa, which is part of the frontal bone. Now we will discuss the medial wall, and as you can see, it's formed by four bones. We have our lacrimal bone, which is over here. We have our, sorry about that, this should be the ethmoid bone. So we have behind directly the ethmoid bone, posterior to the lacrimal bone. Then we have our maxilla, situated a bit inferior to both, and it's a small part that contributes from the maxilla. And the lesser wing of this sphenoid bone is the posterior most, and it's the least contributing. So the four bones are those. Now there's two landmarks that I would like to mention in this region. The first being our lacrimal groove. Now, where is this lacrimal groove? It's over here. So this is our lacrimal groove. It's found between the lacrimal bone and the frontal process of the maxilla. So let me label it. So this is our lacrimal groove. So what does the lacrimal groove do? So the lacrimal groove hosts our lacrimal sac. This is the lacrimal sac. And again, this is our lacrimal gland. Okay. One thing I forgot to mention earlier is that the lacrimal gland is found superior laterally, as you can see here. And if it's found here, obviously our lacrimal fossa will be in this site as well, superior laterally. Please don't mix up between the lacrimal fossa and the lacrimal groove. The groove is found medially and on the medial wall. The groove hosts the lacrimal sac, and the fossa hosts the gland. And this is the first structure I want to talk about. The second part I want to talk about is those little kind of circles. If you can see them, I hope you could. So what are these? So basically, now we're in the ethmoid bone. And as you may know, the ethmoid bone has its ethmoid air cells. So these are the ethmoid air cells. You can see them. So in here, because of the air cells behind the bone is not thick. So in here, unfortunately, the bones are thin. And this is important clinically, as we will discuss later in this video. Now, one more thing before we move on. This third structure I'm going to show now, it's not really part of the medial wall. However, it is related to it. It's this one I'm highlighting here. So over here is the point where the trochlea is found. So the trochlea is found here, the cartilage we spoke of earlier, and it's located superomedially. And now we can move on. Now we will talk about the floor, also known as the inferior wall. And in here I've hidden the frontal bone, so I faded it so you can observe clearly. So it's made out of 3 bones: the maxilla, our zygomatic bone, and posteriorly the palatine bone. There is one important structure you should know here, and it's this one I'm highlighting, this opening. So this opening is known as the inferior orbital fissure. So what's the function of the inferior orbital fissure? It's basically an opening where a lot of important neurovascular structures pass by. For now, we're not gonna talk about them. There's a separate video for them. But all you need to know is that the inferior orbital fissure separates between our floor and our lateral wall. Okay? Now we will discuss the lateral wall. It's only made out of 2. It's made out of the greater wing, finally, of the sphenoid bone and our zygomatic bone. And there is one structure again you need to familiarize yourself with, which is this one. And nope, this is not the one we discussed in the floor. This is a different one. This is the one we discussed before. It's over here. This is the superior, as probably you guys guessed, superior orbital fissure. So again, neurovascular structures pass by. Only thing you need to know is that it separates the greater wing of the sphenoid from over here the lesser wing of the sphenoid bone. And this sums up the details, the anatomic details of the orbit. Now we will move on to discuss the clinical relations. So the most common clinical condition related to orbits is fractures. So why do we concern ourselves with fractures? Obviously there are other things such as neoplasms, but they're not that common. The most common ones are fractures. So which margins or walls actually are more prone to fractures? I'll let you guess. I'll give you a couple seconds. Okay, time's up. So the wall that is most prone to a fracture is actually the floor, the inferior wall. That's because when most people trip and fall on their faces, the floor of their orbit hits the floor of the ground. So that's an easy way to remember it, floor to floor. So it's the most common site where a fracture happens. Now you guys would probably guess what is the second most common one, and yes, it's the medial wall, and it's because, as we discussed earlier, it's because of the ethmoid air cells. It makes this part thinner than the rest. And fun fact I didn't mention before, it may help you down the line, the lateral part where we have the zygomatic bone and our greater wing is actually the thickest part. So yeah, this is the thickest part, the lateral wall. So we don't have a lot of fractures in the lateral wall. We have some in the superior, but mostly it's the floor and followed by the medial wall. And before I move on, there's one more thing I need to mention, is in the fractures in the floor, if the entire floor is fractured, so it's not like a part of it, the entire thing, so it basically collapses. So if it collapses, the fracture has a special name, and you will come across it a lot in ophthalmology. They're called blowout fractures. So now you know what a blowout fracture is, okay? Now let's say we have a fracture in the medial wall. This entire slide is dedicated only to medial wall fractures. So medial wall fractures. So this is a coronal section over here, and this is a sagittal section. So where would the air cells be? Over here. This is the eye, this is the air cells, ethmoid bone would be here, this is our medial wall. So if a fracture happened here, what will happen? Let's move on to the right side. So again, this is the cells. So if a fracture happens at this site, what would happen? So on top over here, we have our cranial fossa. And over here we have the ethmoid air cells, which are, as you can see here, they're part of the paranasal sinuses. So what happens is that your cerebrospinal fluid would leak from the cranial fossa into the paranasal sinuses. And when this happens, your CSF decreases in volume, and as the cerebrospinal fluid decreases, you will have like a drop in your intracranial pressure, and this manifests as headaches, nausea, vomiting, maybe like a feeling of fogginess or like a difficulty in concentrating. So this is pretty serious, like they could get really serious. So you need to watch out for a medial fracture. Also, like for if a fracture happens, obviously the fragments of the bones could fly around, and one of them could hit the eyeball itself. And once this happens, it could obviously lead to blindness. So it's also serious. So we always like for fractures we do CT scans. You could do an X-ray, but mostly CT. Both of these are CT scans. This is a coronal view and this is a sagittal one. And one more thing I want to mention is when this scenario happens, this is called a craniosinus fistula. A craniosinus fistula. And that's pretty much all what you need to know as an undergrad medical student in the clinical relations. I have one question for you before I leave. Which of the following walls is the least likely to suffer from a fracture? You have the roof, medial wall, floor, lateral wall, the Berlin wall. So which of these walls is the least likely to suffer from a fracture? Leave your answers in the comments below. And thank you so much for tagging along. I hope you have a nice day and good luck with all of your studies, guys. Take care.